This is the kind of disease we want to document. You can see there's a huge aortic, common iliac bruit here that is causing all of that color speckle within the area. But this is from a severe common iliac stenosis. We can see here that this is over 500 centimeters per second, certainly a hemodynamically significant stenosis by anyone's criteria. In order to determine that there's at least a 50% stenosis, we have to have a doubling of velocity plus post-stenotic turbulence documented from, so we would have a doubling of velocity from the segment of the artery prior to the stenosis as compared to the highest velocity within the stenosis, and then we'd want to document that post-stenotic turbulence. Here's another example of a severe common iliac artery stenosis over 600 centimeters per second. It's aortic, and the loss of the reverse flow component, certainly a very stenotic. Here's an example of an external iliac stenosis. So here's what I was talking about. Here's the pre-stenosis waveform. It is monophasic. It doesn't have a diastolic component. Then we get into the highest velocity and then document the post-stenotic turbulence distal to the stenosis. And you can see here how color will help you place the Doppler in the highest velocity segment where that's aliasing. Don't forget about B-mode. B-mode can show you also where the plaque is, and you can sort of get an idea of where you're going to be putting your spectral Doppler to confirm whether or not this is a hemodynamically significant lesion. This is an example of diagnostic criteria. Some centers will use greater than or less than 50% stenoses. Others will break that down further into 50 to 75 and 75 to 99 based on these criteria. Occlusions, of course, you have to confirm the absence of flow, and normally we'll hear a pre-occlusive thump just proximal to the site of that occlusion, and then confirm that it's occluded within the vessel segment that is occluded. So let's look at a case. This is an aortoiliac case of a 75-year-old male with bilateral lower extremity claudication. He had calf pain at 2 to 3 blocks. He had the other usual comorbids and was a prior smoker. The study was prompted by decreased femoral pulses with absent distal pulses, although he had patent Doppler signals at both the DP and PT. He did undergo a physiologic study that showed likely aortoiliac disease, and an aortoiliac duplex was ordered to define the extent of this disease. So let's just walk through what we would normally collect in a complete exam of this type. We would look at the proximal aorta, the mid-aorta, and the distal aorta. We would be looking for any aneurysmal dilatation as well as any stenoses while we are assessing this in both transverse and longitudinally. Then we look at the origins of both common iliac arteries, and you can see that there's quite a bit of difference in the waveform here. This is a much more normal waveform on the left, where there is some reverse flow component, as opposed to this on the right, where it is a monophasic waveform and there's no reverse flow component. So we're going to be keeping an eye out on that. The right common iliac was patent throughout, with about 100 to 125 centimeters per second. As we come down into the right common, we see the bifurcation of the hypogastric or internal iliac, and then the proximal or proximal to mid external. As we get just a little further out in the external iliac artery, we see a step up in velocity of almost 500 centimeters per second, with additional increase in velocity at the origin of the internal iliac artery. Again, over 400 centimeters per second. Here's a depiction of where that is by color flow. You can see in the external iliac right where that lesion is occurring. And then distal to that, we have the post-stenotic turbulence and decrease in amplitude and velocity, and the waveform is quite disturbed, which confirms that that's a hemodynamically significant stenosis. Finishing out that side of the exam is documentation of the right common femoral artery and the runoff vessels PFA and SFA. All of these vessels then are monophasic. We then go to the left, and we again see the left common iliac artery origin, and there is some step up in velocity there, but it doesn't double from the previous segment, and there's no real post-stenotic turbulence associated with that. We continue on down to the rest of the common iliac and then get into the left internal iliac artery, which, similar to the right, also has an elevated velocity, and continue down the rest of that segment as well. When we got down to the level of the femoral, we noticed that the left SFA is occluded, and confirmed that with spectral Doppler. And here is a left profunda adjacent to that, that's 251 centimeters per second. Here's the PFA distal to the origin. And so the question is this PFA stenotic with this step up in velocity? Well, the answer to that question is there's no post-stenotic turbulence here, and this PFA is simply compensatory for the occluded SFA, so it's not really stenotic. The impression on a case like this would be hemodynamically significant stenoses of the right proximal to mid external. Remember, we had that very high velocity with post-stenotic turbulence. Bilateral internal iliac or hypogastric stenosis. Bilateral patent common iliac arteries and left iliac artery, external iliac artery without any hemodynamically significant stenosis. The occluded left SFA with the compensatory profunda or deep femoral. In summary about pre-intervention aorta-iliac duplex ultrasound, it complements the routine diagnostic workup. It's good for selective use in pre-intervention assessment, and it may assist in determining appropriate intervention, particularly for endovascular interventions, and it may be able to predict the success of endovascular procedures, specifically by looking at is the disease diffuse, focal. If it's really vastly diffuse, this patient may not be a candidate for endovascular intervention. We can also determine if more focused or limited angiogram is appropriate rather than a full diagnostic angio. Many of these patients have other comorbid problems like marginal kidney function, and it may be helpful not to give them a full diload. We may be able to determine the suitability of the endovascular repair versus an open surgical repair just looking at the anatomic structure, if it's focal versus diffuse disease, and what the hemodynamics are within the segments. This role in patient selection and procedural planning prior to intervention can be accurate, cost-saving, and time-saving, but it does require high-quality resolution equipment and experienced examiners and interpreters. We'll move on now and go from the pre-intervention to the post-intervention assessment. This is done with selective use. We're going to use both imaging and Doppler data just like we did in the pre-intervention and look at that pre-op for comparison. If there was a stent placed along the course of this intervention, we're going to look very carefully at that stent alignment and the relationship to the vessel wall. The rationale for looking at patients in the aorta-iliac segments after intervention is knowing that identification and treatment of restenoses prior to complete occlusion may improve long-term patency. We know that stenoses are technically easier to manage than occlusion, and that PTA and stent procedures are associated with a pretty significant restenosis rate, and we want to find those and intervene prior to losing and having that segment go down.